essentially disappear. Now, it doesn't disappear from the body, but it goes from being viable to being dead within a few minutes. So I did take the liberty of a little bit of time lapse, but this is only a 10-minute treatment. By the time we get to the end, this tumor is essentially completely treated, and this is again overall about a 30-minute surgery. So this is about a 6-centimeter tumor. That's important for the topic of prevention and screening because this is already at a size that is beyond the criteria for transplant. So this patient, even though this is a successful outcome, we've already missed a window of opportunity for potentially curative transplant. What about bigger tumors? I mentioned that transplant is really only suitable for patients with very small tumors. What do we do with tumors that are 5, 10, 15 centimeters? Well, this shows almost a volleyball-sized tumor in the mid-abdomen. Normal, this is the healthy liver over here. And if we move forward through the operation and slowly separate away the healthy from the unhealthy, you can see we're left with what looks like relatively healthy liver. The tumor's been removed from the whole abdomen. You can see the blood vessels underlying the liver. If we skip forward to the final session, you can see the tumor itself after removal. So again, volleyball-sized tumor, but it can be successfully removed because of the feature of the liver that allows regeneration. So why is this all? This patient needs a so-called Whipple procedure, where the head of the pancreas and the duodenum is removed, and in this case, the portal vein, which is that blue structure there, has to come out as well. When the tumor is removed, it'll be reconstructed like this. So what this shows, I'll fast forward this a bit. This shows the tumor. Blood vessels on each side. The tumor cannot be separated, so clamps are placed on the blood vessels. The tumor is removed, and a piece of jugular vein, which you'll see here in a second, jugular vein from the neck, is placed as an interposition between the two ends of the blood vessels. So the tumor is removed, the blood vessels taken with it, and this is actually a very safe operation. We don't need both of our jugular veins, believe it or not. So one of the jugular veins is taken, and it's used as a graft. Blood flow is restored, and you can see here in the final picture, the tumor's been removed. If I get my hand out of the way here, the tumor's been removed, and that the margins are all clean. And this is one of the ways that surgically we can deal with tumors surrounding blood vessels. But what if we get in there and we simply can't remove it? That's where this very exciting technique called electroporation comes in. A few minutes ago, I showed you a type of ablation that uses heat, where we put needles into a tumor and then hooked it to a generator, and that caused heat. That's called thermal ablation. This is a technique of electrocuting tumors. Probes are placed around the tumor, and a current is sent between the probes. That causes the cells to basically dilate, to lose their ability to control their own permeability. So it's called irreversible electroporation. And this is a technique that's now being used to fight pancreatic cancer. And in fact, can be used in place of surgery in cancers that can't be removed. Just to go home in 3 or 4 days. This is the pancreas. So we're lifting this up off the kidney here, freeing it up completely. Here's spleen over here. So the pancreas is attached to the spleen, just like in that drawing you saw. And we're going to take a manufactured stapling device, which comes through the vessels here to try to free up the pancreas. We use ultrasound to make sure that we've got the cyst here. We use another stapler, which comes across the pancreas, removes about a 2-inch piece of pancreas, that's put in the bag and pulled out through a 1-inch incision. So the brain is left behind, the case is over, and you'll see the cyst here in a moment. So this is a mucinous cystic neoplasm, and this person has about a 10 to 20% chance of having had cancer, and now their risk is the same as the general population. Well, what if it's a bigger cyst? What if it's right into the spleen and you can't separate it from the spleen? You take the spleen with you? Yes, you can live without a spleen. Yes, you have a slightly higher risk of infection, but it's still a very, very safe operation. This is a similar case. In fact, it looks almost identical at first, but the cyst is much larger, and the cyst goes right up against the spleen. So once again, in this case, there's no attempt made to separate it off the spleen. Once again, we use ultrasound. Once again, we're going to use a stapler to divide the pancreas. It makes our lives much easier than the new stapling devices. The pancreas nice for the tail of the pancreas, but what if the cyst isn't there? What if it's more proximal? As you go more proximal, you start to divide the pancreas here, and then here, and then here. That's an awful lot of pancreas you're taking out. So there's another option, and that is to take out just the cyst itself. Leave the pancreas behind and take just the cyst. So I call these parenchymal preserving options. This is the first of the parenchymal preserving options. Say there's a cyst in the mid-pancreas. We can actually take that out and leave the tail of the pancreas in place and attach that back into the intestine. One end is divided with a stapler, the other end of the pancreas is put back into the intestine. The benefit? Well, you save a lot of pancreas, you save the tail of the pancreas, you save the spleen. This is a case showing this as an example. There's no video here, just the pictures. So this is a CT showing a fairly large cyst right in the mid-pancreas. Here's the head of the pancreas, here's the cyst, and the tail of the pancreas is over here. But when we did an MRCP, and an MRCP is a way to look at the ducts of the pancreas. When we did an MRCP, you can see that this cyst, it's a little hard to see from some areas, but it's not touching the pancreatic duct. It's about 1 centimeter removed, and that allows us the option of what's called enucleation. And in this case, the cyst itself is taken out without taking any pancreas at all. So this is an example of an enucleation. This is in the head of the pancreas. This is the cyst. This is about 3 centimeters, maybe the size of a ping pong ball. We're not going to actually remove any pancreas here. We're just going to peel the cyst itself out of the pancreas. This little structure we're ligating here is a connection to the pancreatic duct. So that's divided so that we don't have pancreatic leakage. There's the cyst. We've got a little defect in the pancreas. We coat this with one of the materials borrowed from our cardiac surgery colleagues. We coat this with bioglue to try to create a bit of a seal. And in fact, no leakage, and she's able to go home with her entire pancreas intact. This is a scan from a year later, and we can see the cyst is gone, and more importantly, the rest of the pancreas is still there. So again, we've taken a risk of probably 20 or 30% risk of cancer in this case, and we've lowered it close to zero.